All right, guys, welcome back. This is part 6 of our little series that we're doing. And I will tell you, that's the fun part, because once we got our IV started, now let's push in some drugs. Yeah, that's what we're here for, right? That's what I signed up for. Let's talk about the different ways that we can give IV medicines, okay? And the normal one that we call it is an IV bolus. And this is usually we inject it into the circulatory system through a portable IV. Check our equipment. And again, we'll proceed from there. And again, now this one actually has a needle in it, so you would use a port. Most of the ones that we have today do not have needles. They actually have lure locks. So make sure that if you're going to give it if you're going to give it in something that doesn't have a lure lock connector, that you have the appropriate apparatus in order to administer it. Again, and make sure that you practice. I don't want to ever hear, I've actually had a third semester student tell me that they don't know how to put one of these together. I'm going to say this politely. Oh, you're going to know how to do this. Make sure that you have doing it at least one time. You definitely need to do that in class. You need to do it in our lab sessions, okay? So, but usually what happens is we'll pull the two safety caps off, and these two pieces screw together, and you'll get a little bit of fluid out of the top of the needle once you screw these together. And make sure that you get the air out. Also, double check your expiration date, please. Yeah, nothing like giving it. By the way, knowingly administering a expired med in the state of Florida is a felony, by the way. So keep that in mind. Clean off your injection port. And again, matter of fact, Shands uses actually these little green caps that go into these. And so they help reduce the infection rates. And actually, again, they work pretty good, actually. So again, when you're doing that, you're going to pinch off your IV line, and then you're going to administer the medicine. And then after you administer the medicine, you're going to flow some fluids through that to flush it through. If we don't have a running IV, then you want to give a flush, at least one flush, probably even two flushes to get that through. One flush for a standard med is usually fine. If I know that I'm going to be giving a lot of medicine, let's say a cardiac arrest, I'm going to hang a bag, okay? Because it's a lot easier to go flip than it is to go, okay, let me get this, okay, and no, that's a pain in the butt. Put your IV tubing, again, hang a bag up there, flow your stuff, okay? Now, by the way, and I want to make sure that you guys understand that there's a difference between an IV bolus, an IV infusion, and an IV drip, okay? I want to make sure a bolus is usually we're pushing it into the patient, okay? An infusion is we're doing it over a period of time and usually with a pretty large volume of fluid, at least 100 milliliters. Well, 50 to 100 milliliters, I would say. And some of you might say, well, D50 is 50 milliliters. That's true. That's a bolus. We're giving it kind of as a one-time thing. But for an infusion, we usually select a drug, and again, we draw up the drug, and we're going to add that drug again to the medication, to the bag that we're going to be giving it. And very rarely, by the way, do we use 1,000 bag for this. Most of the time, we're using like a 100 bag or a 250 bag in order to do that. We insert the drug into the medicine, we mix the solution around, and then we administer our set. Now, by the way, don't spike your bag and then push the medicine in there because, I don't know, the first 50 milliliters of fluid that's in your tubing isn't going to have the medicine in it. It just takes longer for it to go through. Again, and once you do this, by the way, and then you would administer it at whatever rate. And usually we're using a micro drip set if we've added a medicine of some type. Kind of depends on how fast you want it to get in. If it's on a pump, again, we let the pump do the work at that point, okay? Intravenous, again, mix the solution. And one other thing that I didn't see here, guys, make darn sure that you label that bag with what has been added. And like make it really big where they know that it's been added. I will actually usually, if it's a vial, I will actually tape the vial to the bag so that they know exactly what's in that bag, okay? A heparin lock or a medication access port, or a saline lock. These are again, they usually have these these simple locks, or it may have an extension set on them. And again, the reason that they called them hep locks is because they used to push heparin into these. They found out if they just use saline, it's going to work just as well. It helps keep the vein open. The only reason is the heparin lock would technically would not clot up. But the problem is that they don't have a bag of fluid on them. It's just basically a medication administration port for you to use. And on most of our patients, by the way, this is probably what we're going to start on them. Okay. Nowadays, very rarely do you just hang a bag of fluids to hang a bag of fluids. Okay. Even though most people walk around a liter low. All right. So again, venous access devices, they have an intravenous catheter placed into a large vein. This would be your PICC lines. They also have medication ports. As a paramedic, you're not allowed, unless you actually have specialized training, I would say you don't want to use the medication port. Now, a PICC line, I think, is completely different. Usually, we don't allow those to be used. They're really simple. You draw out 50 milliliters of fluid, and then the thing you got to remember is that at that point you have to have a flowing IV line until they re-put the heparin back into the line. So again, it's something that can be used. I think that there's a lot of fear about it that there shouldn't be. Okay, but as a kind of a rule, gang, we usually don't use the PICC lines to administer things. We start our own IV. Usually the reason these people have an IV like that is because there's no access on them. By the way, these port devices, they use a Huber needle. It's kind of like a 90-degree needle, and I'm going to show you guys one of those in class and in the lab session. But again, we usually do not access those ports, especially if it's a subcutaneous port. We just don't do it, okay? By the way, there are electromechanical infusion pumps. And the other thing is that they have something called a dial-a-flow. Dial-a-flows are really cool and actually I'm going to bring that up real quick here. Let's see, I can bring it up. Let's see here. Bring that up there. Dial-a-flow. Let's see here. There we go. And let's see here. Let's click on that. Dial-a-flows, what do they do, right? So basically these are, welcome to our new website. I love it when I have a plan to make everything look good and it doesn't. Tell you what, let's go to images. All right. So dial-a-flow, guys, what this is that it allows us to control the flow rate. It's an extension tubing with flow control to it. Okay. So you can actually dial what rate that you want to have this. The problem is these are they are not exactly perfectly, they work good for certain situations, but I would not use this on a medicated IV in which I needed precise control. If I have that, what I really would like to use is I would like to use one of these guys right here. Now this is a syringe pump, and again, I kind of find it funny because this is supposed to go behind the plunger back here. But there's all kinds of different pumps, and whatever agency you use, make sure that you get trained on this. But I will tell you guys this is that, like this syringe pump, I love this sucker. And it allows for precise control of medications to be administered to the patient. Okay. Now again, we can use the regular hospital pumps, by the way. But if you're going to use them, make sure you know how to use them. Make sure that you know how to, more importantly, to disconnect or shut it off or troubleshoot it before you take it. I can't stress that enough. You shouldn't be taking a pump that you're not familiar with. Okay. Now, ultrasound guided, and I've got a whole other video on this, so I want you guys to watch that one. But basically, this allows you to take a look and see where you're actually sticking the needle and find the actual vessel. The cool thing is you press down on the probe, it actually will flatten the vein so you know which one's the vein. And by the way, the arteries have a pulsating fluid going through it, so you know not to stick that one. Unless, of course, you're trying to start an arterial line, in which case, again, this thing worked wonderful. All right, getting a blood sample. Again, you want to make sure that you do this before you start flowing fluids. The blood tubes, they have a different, they're usually made of glass. They have a vacuum inside of them, and they have a self-sealing rubber top. Again, you can draw it with a syringe, by the way. You can draw it with hypodermic needles and use vacutainers in which to do this. We've already done this in lab, so I'm really not going to harp on this too terribly much. But the biggest thing is that make sure that you check with the staff at the hospital, because if you got a blue top at one hospital, it might be something completely different from a blue top at another hospital, okay? So you really need to find out what it is that they want you to draw from. And again, that's usually site-specific. I would love to say that it's universal. No, it is not, okay? Removing a peripheral IV. Again, want to make sure that you kind of disconnect everything. Again, you're going to occlude the tubing, and then you just remove all the securing vices, and then have a sterile pad standing there waiting, and 1, 2, 3, and you just pull it out very quickly. But when you pull it out, very controlled, very quickly, and at that point, you want to make sure that catheter is intact. And again, swiftly remove it and pull straight back as to do that. Your IVs are great. IOs are pretty automatic. And everybody says, well, why don't we just start IOs on everybody? Well, except, an IV catheter is about $1 each. An IO catheter is around $200 now. So again, and there's a lot more complications with drilling into the bone. There's not as many as you think, but again, if you've got a nice juicy vein sitting there, you are a paramedic. You're quite capable of hitting a nice juicy vein. I would hope so. Again, IOs should be used, especially on conscious patients. They should only be used as a method of last resort. Again, the actual starting of the IO doesn't hurt near as bad, but once you start flowing fluid, there's lots of nerve endings inside the medullary cavity, which would be right here. There's lots of nerve endings in there, and it really hurts, okay? And matter of fact, once you start one of these on a conscious patient, or they become conscious, you probably need to sedate it. 20 to 40 milligrams of lidocaine works very well to numb the cavity, and that's what we want to do. We want to numb that cavity up, and remember that you might have to redose them in a couple of hours, especially if you're taking care of them for a long period of time, okay? Your first push, by the way, should be extremely hard, okay? Because sometimes it is required in order to open up that canal to where it will actually start to flow fluids, okay? Also, just because you're in there doesn't mean you're going to be able to draw back and get anything back out of there, okay? Again, make sure that, and we've already gone over this in class, so I don't want to really, and it's usually a 14 and 18 gauge hollow needle. And again, you're going to insert, this is again the Jamshidi, or again, this is a manual method of doing this. By the way, your easy IOs, you can also put those in manually, although I wouldn't recommend it. The bone gun, I have nothing nice to say about those. I am telling you right now, I'm definitely biased against those. I think that they shatter more bones than they do. It's usually because somebody did it the wrong way. But the big gun, whatever device you're going to use at your agency, please know how to use it. Almost all of them require a pressure infuser. You want to keep the IO under pressure. The reason is it takes more force to get it out into the medullary canal and then into circulation. You want to keep additional pressure on that in order for it to work. Your fast one, by the way, is the sternal IO. I don't know if I gave you guys the video. I think I'll show you that in class. But that video where they actually started on conscious patients. This is the military loves this one. And again, I don't know why exactly. But when you place an IO, make sure you clean the site well. Again, you're going to clean it. You're going to find the location, usually the flat part for there. We talked about, once we started them, is the humeral is actually starting humeral IOs. Remember, this guy down here, it's good for about 1 liter an hour. For the humeral head IO, they're about 5. The reason we usually don't do it in kids is because of the growth plates. Usually a kid below 5, we kind of go for the tibia. It's not to say that you can't use the humeral head. By the way, this is not the only site. The proximal tibia, the distal tibia, the proximal femur down in this generalized area, and then, of course, the humeral head. You can actually use the iliac crest. They're really tiny, small, in order to hit those. Let me just say this, though. If you do start one up here, you can't use this same bone to start it down here. If you start it down here, then all the fluid's just going to come out that hole that you just made right there, and that's obviously no good. Make sure that you secure it properly, guys. Usually we use a pair of small gauze rolls on each side. So make sure that you secure it properly. Good news is Easy IOs, they secure, they're pretty much and even the Jamsheedies here. These guys are usually, once you have them in place, they stay put. Okay. The biggest thing is you don't want to knock them loose. The Easy IO is really hard to knock them loose. But again, then you can give your medicines. And actually, usually what I will do is I'll put a 3-way stopcock here. So if I need to give them push medicine, to give them through that way. And again, remember, anything that you can give through IV, you can also give through IO. Reasons why you want to stay away from certain ones. If they have a fracture in that bone, if you see infiltration in, around, or behind the leg, you can damage the growth plate if you go in the wrong place. So make sure that you go in the right place with this. Again, make sure that you get a good complete insertion. You can get a pulmonary or an air embolism from these guys. They can get infected. The chances of that are highly low, but it does happen. You can get thrombophlebitis through it. Actually, where it comes out through the bone into the circulatory system. Yes, those can get irritated. And yes, you can overload a patient pretty quick on these guys. Contraindications. The big one here is osteogenesis imperfecti. If you have bones that are really brittle, that's basically what that means. Okay. You want to do it. Osteoporotic bones, probably not a good idea to go for an IO. If they fractured a tibia fibula or the humerus, whatever that bone is that you're trying to stick it in, if you think that there's a fracture there, don't do it. All right, the good news is, gang, we finished up our IV and meds, except for the last topic, and we're going to cover that one in class. There is no way that I'm doing drug calculations with you guys in this. There's some things I might throw in there a little bit later and do some medical math with you guys. But I'm going to tell you right now, the medical math is probably the toughest part you're going to get. All right, so the good news is that finishes it up, and we will talk to you on the next one.